Now, you have to go to a doctor eventually, there's no question about it, but much more of the proportion of healthcare services will start to take place other places with a different focus on healthy lifestyle and healthy behaviors in addition to the technology and the medications that you need. So, we look at this and say, if we're an organization whose mission is to improve health, we better get about the business of being focused on this and have some goals for that 8% of the people that we work with needing this to getting to 20 or 25%. And I know that that is possible. So talk a little bit more about the urgency. I love this series of slides. You don't have to say much about it. This is the path of obesity in the United States since 1985. And I don't think there are any set of words more compelling than the picture for looking at what's happened with obesity. So 86, you can start to see we're tracking the information. The darker blue, the higher the rate of obesity. Get to 1991, almost every state is now tracking. You can see the percentages go up. Here we're at 96, and then here's where it really starts to happen. Take a look at this picture. So we move. Now we're starting to get more than 25% of the population obese. This is BMI over 30, so these are not mildly overweight folks. Pretty compelling picture. And then this is what's really interesting. Incidence of new disease, new chronic illness, if you do not even all 4 of those healthy things, but just one more than you were doing before. And you can see the impact is 66% reduction in incidence of new cases of diabetes. We put that off forever? Maybe not, but you might postpone the onset of new diagnosable disease long enough to avoid kidney failure, kidney dialysis, blindness, amputations, and heart attacks. Huge impact to be able to make that change. So here's a place where I would say healthcare reform could go, because some of this is doctor's office, some of this is community, some of it is workplace, but a lot of it is what has happened in our country to change smoking behaviors, can change some of these behaviors as well. And that's walkable communities, easy access to places to have recreation, public policy itself. So changing healthcare, I already mentioned some of the things that I believe are starting to occur, we're wanting to have occur in our organization. Coordinating care. Back when we were 20 or 30 years ago, healthcare was still, by and large, an acute care system. 40 years ago, if you had a heart attack, you generally either died or you laid in the hospital for nearly a month until they finally thought, well, he or she is going to make it, and then they sent you home. Acute care focus. We are now virtually entirely chronic illness focused in healthcare. 80% of healthcare costs are due to chronic disease, 20% due to acute illnesses. We can deal with acute illnesses, again, in very creative ways. It doesn't all have to be an emergency room. It can be urgent care. It can be minute clinic. Those quick, urgently needed, quickly resolved issues, or the big traumatic injuries, we need big facilities to handle those. But chronic illness care, that calls for a whole different set of tools than a doctor and a nurse waiting for you to call and letting you come in for an appointment. Calls for us to be proactive, reaching out to people, tracking the course of chronic illness, tracking blood pressure, tracking blood sugar. Gosh, the set of capabilities to do that online easily, interactively with the nurse monitoring your condition, that's something we couldn't do even 5 or 10 years ago. Focus on prevention. We know what things work to avoid disease, not all the time, but that will certainly make a difference in terms of diet and physical activity and in preventive screening, so we can reach out. 10 years ago, I told people, gosh, my vet did a better job of reaching out to my family for preventive services than my doctor did. Well, we've changed that, but not all the time, not everywhere, and frankly, not American healthcare as a whole. Minnesota healthcare, big strides. American healthcare overall, not so much. Chronic illness care needs to be coordinated. And here again, Minnesota is a system of multi-specialty group practices. Think Mayo, think Alina, think HealthPartners, think Fairview, think Park Nicollet. again, a model not widely adopted and used elsewhere in the country, where you're going to a series of 5 different specialists, none of whom talk to each other or exchange information. There's an ineffective and efficient healthcare system when 80% of healthcare is chronic illness. And as I mentioned, and I'll keep driving this point home, templates, tools, and teams. Healthcare is a team sport. It's not about individual doctors. It's not about house. It's not one genius coming together with a few underlings who know nothing to resolve individual healthcare conditions. And in fact, some of the most underused professionals are nurses and pharmacists. And we have an opportunity as we redesign our teams to incorporate those folks much more effectively. In fact, some of the best outcomes for our patients with diabetes are those that are tied individually to a pharmacist to help manage their medications. So really interesting. This is a little complicated slide, but I'll walk you through it. This is the report card I give to my board of directors. So that AAA, better health, great experience, more affordable health care, began to think about how do we tell our board that we're getting the job done or not. And so I decided to put together this picture to say, first generation, are we delivering? So here's affordability. We looked at average per capita cost with some technological risk adjusters and looked at our delivery system, our 700 doctors, our hospital, and the results in affordable health care. So we were a little above the state average over a period of about 4 years. We've been able to change that position, and we've been able to now be at 91% of the state average. Now, healthcare costs have been going up, so this doesn't mean our costs went down, but it means compared to everybody else, we've become a more affordable choice. And you probably say, well, how did you get there? Does this mean you wouldn't let people in the hospital? Does this mean all those bad things? Well, it means one thing. One of the big drivers was actually using generic medications first. That turns out to be a big element of more affordable health care. Another is we redesigned primary care so that we're using teams in our primary care locations. We focused on measuring our results for our patients with chronic illnesses, and I'll show you the results of the big one in a minute. And it turns out when you do a better job of working with patients with chronic illness, they don't have to go in the hospital, they don't have to be readmitted, don't have to use the emergency room. If you've got congestive heart failure, you can be managed effectively at home instead of showing up in the emergency room time and time again. So the outcomes of really approaching healthcare as chronic illness-based team care using health information technology proactively has changed our quality results, but it's also had a powerful impact on more affordable health care. So I told you we measured the big one, so this is optimal diabetes. I don't think this is the best surrogate for health